Thank you, Dr. Mete, for a nice introduction. Now, I would like to invite Dr. Tan Ban Hock to give his presentation. Please, Dr. Ban Hock, the time is yours.
Okay, I'm sure that after this you don't want to hear any more of me. This is my third lecture today. Okay, so galactomannan. So, like I said, for the longest time, it was very, very difficult to diagnose invasive aspergillosis. So, the scientific community had long been searching for an aspergillus antigen akin to the cryptococcal antigen, which works very well, as you know. And at some point, they discovered this extracellular galactomannan, and that's because they were experimenting with various antibodies that were able to pick up the presence of these antigens. So the truth is that there are quite a few of the substances, glycoproteins, lipoproteins, etc., secreted by various fungi, and in particular the aspergillus, which contain the galactofuran epitope. So the galactomannan, which we are talking about freely, is not really one antigen picked up by one antibody, but they are a family of galactofuranose antigens. And you will understand why it's important to understand this as the lecture goes on. So of course, the whole world was very excited by galactomannan, and the early papers were really promising. So there's this French hospital which looked at galactomannan in their hematology patients, adult as well as pediatric. And they found these patients with confirmed or probable invasive aspergillosis, and a good fraction of them were galactomannan positive. So they had a very high sensitivity, 90%, also a very high specificity, 94%. But in addition to these impressive sensitivity and specificity results, they had several other things that we were all looking for. For example, that galactomannan preceded the diagnosis, preceded symptoms, and preceded clinical signs by almost a week. So this is another famous paper. It's a sentinel paper, again by Johan Martens from the Leuven group. And basically, it's a good paper because they tried to slice and dice the data several ways. So as you know, there's no real gold standard at that time. Actually, there still isn't, I suppose. For the diagnosis of galactomannan, you have to biopsy, you've got to get an autopsy. That would be the ultimate gold standard. But to be practical, these people looked at their data three ways. So in the first analysis, just based on ante-mortem criteria, so anything that didn't suggest invasive aspergillosis, or if you manage to prove that it's not something else, maybe you prove a nocardia, then that's considered a true negative. There's also a category where they included the post-mortem data, and in the last analysis, they included the post-mortem data, but even the probables were considered to be true positives. So as you can see, no matter how you cut your positive and negatives, the sensitivities were very good, 90 and sometimes 100%. Positive predictive values were also good, in excess of 85%. And in addition, there were other tantalizing signs about how useful this galactomannan would be. For example, galactomannan preceded the development of pulmonary infiltrates in almost half their patients. There was no such thing as transient GM positivity, meaning that in the real cases, they had more than one positive result. And of those who had rising levels of GM, all of them died. And for those who cleared, some of them survived. And then there were other data. This one is in the lab where they infected rabbits or mice with aspergillus, and then sacrificed them at different time points, measured the fungal load in the lung, and at the same time measured the galactomannan level in the blood. And as you can see, there's a very good correlation. So I've summarized the galactomannan data here, going back many years. And several things I hope will strike you, that in these papers, they took very high cutoffs, 1.5, for example, to get this sort of sensitivity and specificity. But actually, there's an early hint that maybe it's not applicable in every subpopulation of patients who are at risk of aspergillosis. So in this liver transplant population, the sensitivity was only 56%. And so someone did a formal meta-analysis, and indeed the specificities and sensitivities, when you look at many, many publications, were not as good as the Sentinel papers that had excited so many of us. So in the solid organ transplant group, for example, the sensitivity was only 41%. So what are the problems? So aspergillus is ubiquitous in our environment. It may also exist as a commensal in the pulmonary and respiratory tracts. And sometimes these antigens may be absorbed and they may circulate in the bloodstream. So this is just the antigen, it's not a real fungus in your blood. So a positive GM result is, it's not quite the same as a positive HIV test. It doesn't indicate infection, it gives you a clue, it gives you some idea on the probability of disease. And it's always important to keep this in mind, because day after day, when you look at results, we look at it as if it's a serum creatinine. When you look at the studies, it's also very, very difficult because some of these papers, they were not as statistically rigorous as you would have liked them to be. Anybody with a negative TTNA, for example, would be placed in a control group. We can't help that, right? But we know that the negative TTNAs, the needle is so tiny, with positive autopsies are very well known. For those which are retrospective reviews, you find that as they were doing galactomannans and sending out the results, some of the physicians must have used those results to treat patients. And sometimes if the patient got better, they might have concluded that this was not galactomannan. But then, that would be wrong. So there are all these problems when you interpret the galactomannan studies. And then, of course, like I said, galactomannan, the antibody that is in the kit, detects a family of galactofuranose antigens, which are produced by several different types of fungi. So for the most part, Aspergillus is the most common epidemiologically and statistically in our patients, but there are other fungi that may produce a positive galactomannan result. And later on, I'll show you how clever investigators have used it to advantage. So how do we interpret the serum galactomannan? So to me, I would look at 4 factors. We should consider who the host is. We should consider how it is being used. Are you using it as part of a screening protocol, or is this part of a diagnostic workup, as in the diagnosis-driven approach? Do we have other diagnostic tools at our disposal? Can we combine it with something else, like a CT scan or a PCR? And finally, of course, could this be a false positive? And that's also very important. So who's the host? So this is a very famous paper. It's much quoted. There are many different types of hosts. And there are many different types of people who are at risk of coming down with invasive aspergillosis, but their risk is actually different. At the top would be those with CGD, and of course for many of us, it's the allogeneic bone marrow transplant patient with graft versus host disease. And then of course there's MDS and AML and maybe lung transplant. But kidney transplants, it is a population of patients who are compromised. They are also quite common in this day and age, but their risk is much lower. And then there are people with COPD, for example, with acute exacerbation, or rather with multiple acute exacerbations, lots of exposure to steroids. So those patients are another risk category. And of course, there are patients with CLL, for example, now being treated with agents like ibrutinib, who are also at special risk. So the patient is important, and different criteria have have been published to help you make a diagnosis of invasive aspergillosis in different patient groups. So this is the ASP-ICU criteria, and if you look at it in detail, they actually do not use galactomannan, right? So the entry criterion is a lower respiratory tract culture. So if you're working in an ICU and you're worried that this patient has developed aspergillosis, so you must think like, why would you be worried? So there must be one of these symptoms or signs to make you worry, such as recrudescent fever while still on antibiotics, for example, or the development of hemoptysis. And then you must look for some sort of microbiological data, which would be smear or culture, right? And then we can try to put all the other things together. This is another set of criteria. This set applies specifically to patients with chronic obstructive pulmonary disease. And here, they do give allowance for you to use galactomannan, right? So in addition to being at risk and having COPD, goal 3 or 4, either a culture or a microscopy or 2 positive serum galactomannan tests will put your patient in that category where you can commit him to long-term, costly and potentially toxic therapy with either amphotericin or voriconazole. So number 2, do we have access to other diagnostic tests, right? So like I said, I did refer to this study again by Johann Martens. So in addition to galactomannan, they also use CT thorax, which many of us, of course, use in daily practice. And of course, I also referred to this paper by Ola Morrissey and Monica Slavin, where they combined the galactomannan test with an aspergillus PCR. So I've gone through this, so I won't go through this again, but basically the data you already know. So what's the value of combining it with PCR? So this is a meta-analysis. They looked at various strategies: 1 galactomannan, 2 galactomannan, 2 PCRs, or galactomannan with a PCR, right? So if you take 2 galactomannans, you can increase the positive predictive value to 67%. But if you combine the galactomannan and the PCR, the PPV increases to 88%. And if you are interested in stats, then you can use somewhat more fanciful tools and calculate things like the positive likelihood ratio or the diagnostic odds ratio, and find that the best results, the best likelihood or the best predictive possibilities come when you combine galactomannan with a PCR. And people have done smaller studies. So this concept of combining one test with another is actually very familiar to all of us, right? When we have sputum that is AFB positive, we do TB PCR to distinguish between Mycobacterium tuberculosis and non-tuberculous mycobacteria infection. At a biologic level, it also makes sense because the release of galactomannan and the DNA occurs at different stages of the growth of aspergillus. So this is a laboratory, this is the in vitro, and they found that galactomannan was released during the logarithmic phase when glucose was abundant. But when the nutrients dried up, the mycelium would break down, GM would continue to be released, but DNA is only released after mycelial breakdown. So in life or in the person, it is possible that the host defenses will contribute to mycelial breakdown and therefore lead to some of these different things being released so that you can detect them in the blood. So how should you use the galactomannan, right? Or how do you interpret it? How are you using the galactomannan? So in one strategy, you can adopt a screening strategy. So that's what the Johann Martens study did. They just kept doing GMs every day or twice a week or 3 times a week. But if your patient is on posaconazole prophylaxis, then it would probably be a waste of money to also screen for galactomannan. So this is a study in Spain, and they had this screening approach, but at the same time, they also allowed for the use of galactomannan in a diagnostic or diagnosis-driven approach, right? So basically, they found that large numbers, 188 episodes, so 71+% were all negative, right? No invasive aspergillosis, no IFI was diagnosed. There were 6 deaths that were clinically not IFI related. And then they had 11% that were false positives, right? Because the patient is already on posaconazole prophylaxis. If you have good levels, it is not very likely that he has breakthrough aspergillosis, right? And so a lot of these false positive episodes were actually surveillance results. So the positive predictive value of a screening galactomannan is barely 12%, whereas the positive predictive value of a diagnostic-driven approach use of galactomannan is in excess of 86%. So the other thing is the cutoff, right? What cutoff would you like to use? So most people would suggest that if you raise the cutoff, then of course things like the positive predictive value will go up. And if the galactomannan is persistently positive, that's a bad prognostic factor, right? So it's likely to fail. And this is the recent isavuconazole study where if the galactomannan was going up and up, then the patient was more likely to die. So finally, of course, is this a false positive? And there actually are many reports in the literature about causes of a false positive GM. So antibiotics, very well reported. There's this very famous thing about ice pop ingestion. So like I said, galactomannan, aspergillus is ubiquitous. The galactomannan, the antigen may be absorbed when you eat certain things. Of course, this is a person with mucositis, graft versus host disease. So they have a GI tract that's denuded. And some of these nutritional supplements, which my friend reported. Piptazo used to be a very famous cause of a false positive galactomannan, as shown in this Italian study. But more recently, I think the manufacturer has done something to it, and if you buy the branded Piptazo, it's no longer the cause of a false positive galactomannan. But that's only for the branded forms. I'm not sure about the non-branded or generic Piptazo, right? Now, the interesting thing is that a false positive galactomannan is actually there. It's false positive because the patient doesn't have aspergillosis. So it doesn't mean that it will disappear the next day. So even a false positive galactomannan would have its own kinetics, and there would be a need for that antigen to decay, for the antigen that's detected by the antibody to decay. And these are the curves following. This is all false positivity from beta-lactam treatment. But like I said, because galactomannan can be produced by fungi other than aspergillus, you can actually use it, and clever investigators have used it to diagnose other forms of invasive fungal disease. So for example, you have histoplasmosis, right? You have thalaromycetes. In my earlier slide, I did show that penicillium is one of the genus that will produce galactomannan, and perhaps even fusariosis, although less commonly. And finally, and this is something more recent, multiple myeloma has emerged as a major cause of false positive galactomannan, right? So this is Korea. They find that, so what's a false positive? The index is quite high. The patient does not fulfill the EORTC criteria, and the patient did not require antifungals at all. And they found that there are these false positives, although a false positive never exceeded 3. So very high levels would not be, but when you are at this range, and a lot of the time the results are in this range, you really can't tell, right? And it doesn't really help, right? There are all sorts of the ways in which the GM would go up and down. So, like I said, it is very important to look at the host, to depend on other diagnostic criteria, and maybe other modes such as PCR. So basically, the galactomannan has to be used wisely. I also wanted to say that the laboratory is very important. It's probably not wise to do the galactomannan assay in the mycology lab where cultures are being done. It should be done in a separate room, maybe in a place where various other serological or even a PCR test is being done, because you don't want all these antigens circulating in the air to act as contaminants. So that the quality control in the lab is very, very important. So in summary, I would say that your department has to develop a policy as to how you want to use the galactomannan. You can use it, for example, to screen febrile neutropenics if they're not on mold-active prophylaxis. And if you are using galactomannan as a diagnostic tool, it's good to send more than one test. It's important to look at the other circumstances, such as the host and what the CT thorax features are. And it may be important to combine it with one other modality, such as a PCR. Thank you.